I guess now we're ready to move to the kind of group discussion time. I do have a few questions. I guess we can have all the speakers coming back. So we have Dr. David Levy, David Mendez, Tony Blakely, and Dr. Salazar here. Yes, so I guess I will start, probably try to kind of have one question for each speaker. Great, so the first question is for Dr. Levy from chat. So the question is, can we apply those numbers to how much in healthcare costs Medicaid and Medicare would have saved from lung cancer? I assume you might have done some estimates like that, but.
Actually, that's something I haven't done. I would point to, well, not specifically for Medicare and Medicaid, but Tony Blakely's group has, I believe, looked at costing. You know, in terms of sorting out for Medicare and Medicaid, you know, you really need to you need a more complex model. For Medicare, people over a certain age, for Medicaid, people below a certain income. So the model that I developed really isn't suited to do that. You would need, you know, as I kind of indicated, a disparities model, and I guess I could sort out by age, but it would be a little bit kind of tenuous, and there's a lot of complications with Medicare and Medicaid.
Can I chip in there?
Yes,
yeah,
please.
So for the New Zealand analysis, 5 million people, roughly about $1 billion saved in health expenditure over the next 20 years with a 3% discount rate. The US is 60 times the population size, so that's 60 billion. The US loves spending money on the health system, so that's probably about 100 billion because of the way that it works out. That 100 billion over 20 years, the way that the model works, it tallies up the saved expenditure because you avoid heart attacks, you avoid lung cancer, yada, yada, yada. It also allows for the fact that you live longer and therefore you incur expenditure elsewhere. So it is a proper representation, if you like, of the full impact on the health expenditure. So there you go. Rule of thumb, it looks like about 100 billion over 20 years would be your first estimate for a healthcare savings in a country the size of the US. Very rough.
Great, thanks for the numbers. I do agree with the point that if people live longer, right, you're probably going to see other healthcare related costs. And that's something I think is missing in a lot of the estimates.
Yeah, it's very important to discount your estimates because those people are going to be alive way into the future. And if you don't use a discount rate, it will change those numbers a lot. So there's a lot of subtleties in here.
Yeah, maybe we can get another team looking at these different costs. I think we might need market scan data too for private insurance, given how complicated the health insurance is in the US. The next question is, I'm going to be a little selfish. So I do have a question for David and David here. So I think the focus of the presentations today is on very low nicotine content cigarettes. So I wonder, my question here is it possible that some of the smokers will switch to other combustible tobacco products, such as cigars, with the regulations on very low nicotine content cigarettes? Has any of the models looked at this potential substitution effect across different products?
I'm working on a model that it won't be done with this model. And by the way, your point is a very good one. And really, I think in the United States, for a nicotine standard to be effective, it would at least need to apply to little cigars and, the smaller non-premium kinds of cigars. Otherwise, I think there is a lot of potential for substitution. I'm developing a model with cigars, so and so I'll be developing more, looking at the kind of substitution effects that are needed. But that's a great point, and something that I think the FDA will need to consider, especially in terms of the implications it would have by racial, ethnic, and probably also by SES too, and illicit markets, but too. But anyway, sorry, David. Did you anything you want to add?
No, I don't want to add anything more to what you said. So the model that we consider that I presented just encompasses what we call combustibles in general, right? So as David explained, the assumption is that you are not going to have a viable combustible alternative, but we hope that we are not going to have a viable combustible alternative to switch to.
Right. How feasible is it for FDA, I guess, to regulate all combustible products at the same time, or is that something we're thinking about pushing for?
Feasible? I mean, they have the capability to do that, right? So and as David says, I probably cigars were not going to be part of the equation, but something that can substitute for cigarettes. I think it would be it would be missing the point to the policy if it's not regulated. If you keep enough of those combustible product that people can switch to and not regulate the nicotine.
Great, thank you. And I have a question. Well, not I. There's a question for Dr. Blakely here from Raphael. So congratulations on your work and kudos for developing projections for Maori and non-Maori populations. So there's a kind of a technicality question here about the model. How did you model the combination of policy scenario? Did you assume multiplicative effects?
That's a great question. So there's kind of two ways you bring policies together. You can kind of do it at the back end of the model, whereby this component of the intervention to change the incidence rate by 20%, this by 5%. It won't be quite 25% because the 5% only acts on the remaining 80%, and you bring it all at the end. That's at play in here when it's allowing for the competing mortality and morbidity risk. But really, the question here is about the front end of the model, because that's working on the smoking, vaping part. So, for example, if you start with the denicotinization model and you've dropped your smoking prevalence from, at some point in time in the future, from 10% all the way down to 2%, then your smoke-free generation will only reduce it further based on the rump of people in there that are still smoking that were born after 2006, and with an additional percentage reduction of those remaining people. So, for example, if the number of smokers who are age 25, say, and the model was 15% under BAU, and it goes down to 5% under the denicotinization, and then your model assumptions assume that the smoke-free generation will reduce it by 90%, it goes from 5 down to 0.5%. So it is kind of like multiplicative in that part of the smoking life history course, as well as being dealt with in the back end. I hope that answers the question.
Yeah, thank you. I have one more question, I think, for Dr. Levy from Stefan. So given the tobacco industry has been able to modify nicotine levels in cigarettes since roughly 1920, if one looks at granted modified risk tobacco product designations by the FDA, there seems to be only one combustible cigarette containing 95% lower levels of nicotine. So being an actual very low nicotine content cigarette, as talked about today in the presentation. So the question is, if there is something special to producing such kinds of cigarette, if there is something special to producing such kinds of cigarettes, and might that have been the reason for them not being available more broadly?
I mean, yeah, I think that's an important point, but I would point out that the other David looked at gradual implementation, and that kind of gets around the problem. To my knowledge, and I'm far from an expert on the manufacturing capabilities or any of that kind of thing, but I think they can do that. I think, one of my co-authors, Mike Cummings, we talked about that, and he didn't think that would be a major problem. And the other person I think who can help answer on this is Tony, because they're actually implementing a standard. So I would expect that they've thought about this issue.
And I'd love to throw that.
Can I chime in? I'm sorry.
You go first, and then I'll speak to it. Yeah.
Yeah, another issue, another possible. I'm not expert in that, but another possibility of why you don't see more of those low nicotine content is that nobody would buy them, right? So I mean, we're talking that people, are attracted to nicotine. So if there's no policy to reduce nicotine, and if it is legal to have high nicotine outside, why would people just go and get something that is the same harm as harmful as the other cigarettes, because you are just burning tobacco and you don't get the nicotine that you are craving, right? So I think that the idea is that these products are going to be they are going to be marketable when there is a policy that prevents individuals to buy full nicotine tobacco, cigarette.
Richard Edwards just unflicked his mute. Can you pull him in, Ruoyan? Because Richard knows this stuff much better than me, given I'm now in Melbourne, as to actually what's been done. And there is now a timeline, whilst Richard's coming online, of when this policy will be implemented. So let's hear from Richard. He knows this better than me.
Oh, thanks, Tony. So the policy is due for implementation on the 1st of April 2025. And exactly how it's going to be implemented and how the tobacco industry is going to respond is not yet clear. I mean, you can certainly, I think, as other speakers have talked about, you can make low nicotine cigarettes either through using low nicotine tobacco, which is genetically modified or selectively bred, or you can extract the nicotine from sort of standard tobacco plants, if you like. But what we're not clear about at the moment is what the tobacco industry is going to do, whether they're going to produce these products for the New Zealand market. There is a company, of course, 22nd Century, that does make low nicotine cigarettes, mainly for research purposes up to now, although I think they've launched low nicotine cigarettes in a couple of states in the US. So they're upscaling in their production, and they are a potential company that could supply the New Zealand market. But exactly how that's going to play out, we don't know at the moment, or I don't know at the moment, and it's a matter of watch this space.
Great, thanks for the contributed answer. So there is actually a question from the audience related to the 22nd Century. So it's from Lay. So Mitch Siller previously mentioned that the 22nd Century has an FDA approval, very low nicotine cigarette. Do we know that how successful this has been? Has any other companies applied to FDA for approval? Is any of the big tobacco companies trying to apply? I guess this is to all the presenters today.
Sorry, I don't know.
I'd be surprised if they have, but I've been surprised before. Oh, Mitch is on. Great. Yeah, it would be great to hear.
The submission of an application to FDA is not a matter of public information. So if some other company has submitted for a very low nicotine cigarette, FDA can't reveal that. The company can, but FDA can't. So, so there's no way to know what, if anything, is pending before FDA. I think that sales of the 22nd century very low nicotine cigarette have been very slow. They've been doing some test marketing. To me, from a regulatory and public health policy perspective, it's proof that it can be done. It's proof that it can be commercialized. And if you're to believe the executive leadership of 22nd century, they believe that they can produce enough of the genetically modified seed to supply the entire U.S. cigarette industry. They've at least made that claim. I think the best way to look at this is it's clear that it's technologically possible. I think the only open question from a compliance standpoint is this is just for the U.S. How long would it take for the companies to have enough tobacco on hand before such a rule went into effect so that they could continue to sell cigarettes, but in compliance with the product standard? And expect that to be an issue that will be the subject of industry comments after a proposed product standard is issued by FDA. But to me, that's a secondary issue. It's how much time do they legitimately need, which could be a legitimate question, which the agency will have to sort through with information provided by the industry.
Great, thank you. I think that answers the question. So the next one is for Dr. Blakely about the inequality analysis. So the Maori versus non-Maori analysis is great. Have you had a chance to examine disparities according to other socioeconomic factors such as education, income, or poverty?
Not yet. So up here with the SHINE group that I've established in the University of Melbourne, this is a technical answer, but I hope people understand why I'm doing this. We've created software in Python for the whole models that we've got. And we've also got this, what we call a heterogeneity module that automatically splits populations apart. Now, that's going to make us much more easy to do this because actually the New Zealand stuff was a lot of work because essentially we had to separately specify Māori, non-Māori by male, female, so 4 different population groups. Now, we could do that because New Zealand really keeps careful track of that data. For other countries and also for doing it by SES in New Zealand, but also we're now doing Australia by SES by indigeneity. Sammy Howe, who was on this call, her PhD, she's carefully getting all the data together on the tobacco and vaping scenarios going forward by every possible combination of sex, by age, by indigeneity, by SES, by rurality. Because then you can pull out, once you've got that file, whichever grouping you want. So that's at the front end of the model. At the back end of the model, that heterogeneity module will pull in all the GBD data and then automatically disaggregate it by those groups if you tell it what the rate ratio difference is in incidence rate between Aboriginal and non-Aboriginal. So it's quite easy at the back end. There's 2 parts to do. The front end on the tobacco and the vaping, you've got to get all that stuff done. And then at the back end, we think the best way to do is data science, where basically you're just using these algorithms that automatically split it apart. So that's where we're at the moment, and I would hope to see in the next 5 years that lots of countries are starting to do this by using a blending of epidemiology and data science to pull it off.
Great, thank you. I guess the analysis results will probably be published in the future, right, from the group?
Yep, so we're moving to Australia at the moment, and we will be publishing first by SES differences. We've already sort of used that automatic heterogeneity module to do stuff for cold housing by SES, so we're starting to get that machinery up and moving, whereby you can do that. And just for other countries, we've got all these pipelines coming in of all the GBD data. And as long as the country knows that, say it's Canada, and they're doing the difference between low and SES, if they know what the incidence rate ratio of the different diseases are, as well as the difference in smoking, vaping, they can all come together in this software architecture to give those estimates. It's a lot of work to do it. So what we're trying to do with the Shine is create the infrastructure that other people can use, because there's a lot of deep software engineering to do all this. And then the user just comes along with their input variables to lay on top of the GBD data and with their own sort of smoking, vaping stuff as well. That's where I think the future is, by trying to do it that way.
Great. I have a quick question. I guess, is this model or like this technique open to the public? Is it accessible through the website or?
I assume that question's still with me. No, not yet. So we've worked it up for our group, and now what we're doing is we're working with quote unquote trusted colleagues. So we've got people at Deakin University, people at Otago University back in New Zealand, but we're starting to get them to use the Shine infrastructure to test outside people using it. And then we hope to get to a point in a year or two where we've got, maybe David Levy wants to run his models on our models to compare them. Because it's, like SysNet, you want to be able to compare different model structures to see if you're getting roughly the same answer. We're not quite ready for David Levy to give me a call and say, I want to use your model. But hopefully in a couple of years' time, we'll be able to have that portal where people come in. But at this point in time, it would be collaborating with us and working with our team to run the model on your behalf, which actually means there's got to be some dollars associated because that actually costs us money. But we're trying to move forward to that position whereby there's some way that people could get a license or a way to use it.
Great. That plan sounds awesome.
Can I make a comment? Yeah, I'm really glad to hear that, because I like Tony said, I multiple models usually give increasing credibility, it's tough to make models public, and it's a bit scary because you're giving away some control. Related to that, though, and Raphael could speak to this. We have made our not the model I presented today, but the one that projects forward with e-cigarettes. We've made that available through the TCORS website. And I should say, I think that's a much simpler model than the New Zealand models, where I'm sure you're going to have to deal with a lot more issues.
But simplicity is good, because sometimes you just need to do stuff simply, quickly. And that's what David have excelled at, is doing multiple countries quickly but simply. And it probably gives the right ranking, right? And we're trying to move on to the next generation of sophistication. I should just mention one more point, is the models that we do at the moment are probably okay for OECD and high-income countries, but they're not going to work for middle and low-income countries because of different maturity of the tobacco epidemic. And so the one thing we want to do when somebody gives us funding is to evolve our model to not just use current, X and never, but to bring in all that GBD stuff on the pack years by country. Because once you bring in that pack years, you then are capturing the different maturity of the tobacco epidemic and can start doing analyses that capture the fact that smoking's more recently taken up in Papua New Guinea or India or wherever. Haven't done that yet, but I think that's an important evolution to do in the next 5 years, so that you can have analyses that are actually more comparable depending on how mature your country's tobacco epidemic is.
Great. So I have another question for all of the speakers today from the audience. So it seems none of the models presented considered smoking intensity, for example, cigarettes per day. Is that correct? And if so, would you say that the models might underestimate the potential benefits from reducing doses of cigarettes?
I'll jump on again. Yes, the question, that is correct. We do not include number of cigarettes. And yes, it would probably mean if de-nicotinization reduces the number you smoke, as well as just whether you smoke or not, yes, you'll get a larger gain. And that comes back to why I'm very keen to bring the pack years part in, which will capture that into one way. That's correct.
I would like to jump in on that question as well. which is related to one of the limitations of the DPN model, not only related to stratifying by like race, ethnicity, right? Also related to tobacco use intensity. And there is maybe the challenge is the data, right? To populate those models, right? If we are going to consider another level of, I will say, a stratification in the model, we also need to be very careful about the data we need, right? To populate that specific subgroups. The data that other presenters have been discussing, right, about like mortality rates or relative rates related to different populations will be helpful in the future, right, if we would like to rerun those models and to incorporate additional subgroups. But I think some model approaches are it's feasible to include those additional stratifications, but the challenge is how to use reliable data, right, as input parameters to populate those subgroups.
Thank you. Yeah, I definitely think that.
Let me jump in a little bit. So we in our modeling initially for the low nicotine or the nicotine reduction, we look at the effect on reducing the number of cigarettes per day. With the data that we have, as coming from CISNET and from Dorothy Hatsukami's work, then we did not see a sufficient jump in the in mortality rates because of that jump in cigarettes per day. So it wasn't sufficient action at that point in order to see, give us any effect. So we can revisit that, but that was the reason why we went into more cessation and prevalence, use or no use, rather than the reduction in intensity.
And one other point, and I'm kind of going out on a limb here because this is not my area of expertise, but it seems like compensation might be a factor. In other words, people might, smoke closer to the butt and inhale more deeply to try to get what limited nicotine there is. I mean, I don't know. I think Dorothy Hatsukami can speak much more reliably to this than I could.
Yeah, we don't see any compensatory smoking over time. We might see greater intensity of smoking when people just immediately switch over to very low nicotine content cigarettes because they're thinking that they could probably get a little bit more nicotine into their system. But I think they realize that it's just almost impossible. If you're reducing the levels of nicotine in cigarette by 95%, it is just very, very hard to get to a level where they feel any kind of satisfaction. So we don't really see, over time, any change in intensity of smoking.